Welcome to the High Risk Pregnancy Training Academy, where ANMs, medical officers and specialists come together to learn about high-risk pregnancy conditions, share experiences and work together to ensure the best health outcomes for mothers and babies. Today we are learning about the identification, treatment and management of the high-risk pregnancy condition of tuberculosis in pregnancy. But first, let's meet our expert trainers.
Hello everyone. I am Dr. Karishma Tharyani, a senior obstetrician and gynecologist practicing in New Delhi. We all know that Government of India has started many programs for the diagnosis, prevention and treatment of tuberculosis. But still, tuberculosis remains a major health challenge for the country. It is the women of the reproductive age group who bear the major burden of the disease. Tuberculosis in pregnancy can have adverse implications on the health of the mother, fetus, and the neonate, with severe short and long-term implications. So today, to understand the management of tuberculosis in pregnancy, we have with us Dr. Poonam. Dr. Poonam is a senior consultant, maternal and fetal health at CFMC New Delhi. Welcome, Dr. Poonam.
Thank you, Dr. Karishma.
So, Dr. Poonam, could you please highlight how tuberculosis in pregnancy adversely affects the health of the mother and the fetus?
The tuberculosis has a sequential effect on the mother and the baby. In the baby, it can be in the form of, rarely in the form of congenital tuberculosis, but there is a possibility that the neonate can be affected by the active case of tuberculosis in the mother. In the mother, it can lead to repeated reproductive failures in the form of miscarriages, preterm deliveries, problems with during the delivery as well, and therefore it has to be looked into in depth, which is what the Government of India is doing. The active cases in India is also remarkably high and is about 20% of the whole global, the burden of active cases that is there. We assume that it could be as much as 45,000 per year in the near future. So it has to be dealt with in details, and everyone who is a healthcare worker needs to know about it and how to refer these patients to the appropriate center.
So tuberculosis in pregnancy can have adverse effects on the health of both the mother and the fetus. In the mother, it can cause reproductive failures, difficulty in conception, increased abortions, and increased maternal morbidity. In the fetus, it can cause increase in the rates of preterm birth, intrauterine growth retardation, and congenital tuberculosis. Dr. Poonam, are there any signs and symptoms that the ANM should know so that she can suspect tuberculosis in an undiagnosed pregnant woman?
Certainly, there are certain signs and symptoms which the ANM should be looking for, particularly cough, which has been lasting for more than 2 weeks, fever lasting for more than 2 weeks, any history of hemoptysis, which is blood in the sputum, or the feeling of being unwell in the mother. These are something which or the symptoms which the ANM should be looking for. Occasionally there can be a presentation of an intractable headache, which can also signify certain rarer causes of tuberculosis. Looking for extrapulmonary tuberculosis in the form of swellings in the body, and again the feeling of malaise and fatigue which goes on for a long period of time should alert the ANM about tuberculosis.
Dr. Poonam, if a woman who is a diagnosed case of tuberculosis with pregnancy comes to an ANM, how should the ANM manage then?
The ANM has to look for any increase in the symptoms of these patients, make sure that she is compliant to the medication. The medication has to be changed appropriately depending on the pregnancy situation, because there are certain medication which should not be taken in pregnancy, and therefore a urgent referral to the nearest tuberculosis center for changing of the medication, especially if there's a second line of tuberculosis drugs which are used by the patient. Emphasis on folic acid supplementation, calcium, a good diet which includes carbohydrates and more of proteins in the diet, plus adequate rest to the tune of 1 to 2 hours a day has to be emphasized again to the patient and to the family.
Dr. Poonam, you talked about the importance of diet and rest in a woman with diagnosed tuberculosis and pregnancy. Could you please highlight what are the important counseling points that the A&M should keep in mind while counseling such a patient?
So the adequate rest means about 1 to 2 hours, in the daytime, if the patient can have it. With the diet, there has to be an extra 350 kilocalories above the pregnancy calories that is suggested, and a good amount of proteins to the extent of 23 grams per day has to be added. So obviously folic acid and calcium like 100 milligram per day needs to be given, and a good amount of iron needs to be given. So these are important parameters which the A&M should be counseling women about. The role of contact tracing has to be taken with a lot of care, because it is important that anybody who's in contact with an active case of tuberculosis is followed up, investigated and treated. Again, awareness in the family about the tuberculosis, and a referral to the nearest tuberculosis center needs to be done. Enrollment in the National Tuberculosis Eradication Program, also called as NTEP, needs to be ascertained by the A&Ms.
So, Dr. Poonam, if a suspected case of tuberculosis is referred to the medical officer, what can the medical officer do to confirm the diagnosis?
So, the medical officer has to take a detailed history, asking about the duration of the symptoms the patient is presenting with, understanding where this tuberculosis could be. Could it be a pulmonary or an extrapulmonary? And guiding the patient to be compliant to the treatment once the tuberculosis is diagnosed. Now, to be able to diagnose tuberculosis, the patient has to be referred to the nearest DMC, and the investigation that needs to be done would be in the form of CB-NAT. And after the diagnosis, then the compliance and the counseling needs to be done.
So, for the sake of our healthcare workers, I would like to summarize this. DMC is a designated microscopy center, which is present at the level of the village, at the primary healthcare level. At the level of the district hospitals, we have facility for CB-NAT testing. So once a medical officer suspects a woman to have tuberculosis, the medical officer refers the patient to the nearest DMC or to the nearest district hospital for further testing and confirmation of the disease. So, Dr. Poonam, once the diagnosis has been confirmed through confirmatory test and all, when this patient comes for her antenatal follow-up to the medical officer, how should the medical officer follow up this kind of a patient during her antenatal care?
So, every time the patient visits the medical officer, a detailed history is discussed with the patient and noted down in the card that has been provided. The history should be observant about the duration of the illness, what kind of tuberculosis is the lady compliant with the treatment, and whether there are any adverse effects to the medicines that is there. There are certain medications which should not be given to the pregnant women, and this should be highlighted and not given. Patients need to be referred to the DOT center, and the general counseling advice in the form of good diet, exercise, sleeping pattern needs to be discussed with the patient. Now, every time the patient comes in, it is important also to watch for any fetal problems, which can be in the form of prematurity or fetal growth restriction. So, an eye on the growth of the baby is important. And if there is a clinical examination which suggests that the fetus is not growing well, an ultrasound needs to be done, and any changes in the abdominal circumference or the estimated fetal weight which is not falling within the graph, which means that if the abdominal circumference in 2 weeks is not increasing by 10 millimeters, or the weight is not increasing in 200 grams in 2 weeks, the weight is coming down, not increasing. These are the reasons why these patients have to be referred to the referral center, to the tertiary care center by the medical officers.
So, a close check on maternal and fetal parameters like maternal weight gain, increase in fundal height, increase in the fetal abdominal circumference on ultrasound, fetal weight on ultrasound are important parameters which the medical officer has to keep in check. Along with this, the medical officer has to also ensure that the patient is taking her medications on time. She has no adverse effects. She is not taking any medication which may be teratogenic for the baby. In that case, the patient needs to be referred back to the DOT center so that the medications can be revised. And also if she is compliant to her treatment or not. Do all women with tuberculosis in pregnancy need to be referred to a higher center?
So, any patient who has a stable symptoms with the anti-tuberculosis treatment can be managed by the PHC. Any symptoms which is additional, for example, if the patient has cough and bleeding during cough, which is a hemoptysis, or increased breathlessness, or there is any problems that the A&M notices about the baby's growth, are the women who needs to be referred to the higher centers for further management.
So all women who present with new onset symptoms like increase in cough, increase in breathlessness or hemoptysis, women who show adverse effects to ATT in the form of jaundice, all women with MDR tuberculosis, that is multi-drug resistant tuberculosis, should be referred to a higher center because these are the women who are put on second line drugs. These drugs may be teratogenic to the baby. These women may also be offered termination of pregnancy at a higher center if diagnosed before 20 weeks of pregnancy. Other than this, women who are showing fetal implications in the form of prematurity, early onset FGR are the cases who should be referred to a higher center immediately. So Dr. Poonam, in what sort of a facility should women with tuberculosis in pregnancy be delivered? And is TB in pregnancy always an indication for cesarean section?
So pregnant women with tuberculosis can be delivered in centers which have a good NICU facility and the neonatologist being around. Tuberculosis per se is not a reason for cesarean section, and cesarean section should be reserved only for obstetric indications.
So Dr. Poonam, what additional care should be taken in the postpartum period for such women?
So once the delivery has happened, the placenta is sent for histopathology and microbiology investigations. The newborn is examined and investigated for neonatal tuberculosis, and chemoprophylaxis can be started in the neonate. Dietary advice needs to be considered, and this has to be up and above the normal advice that is given in the postnatal period. These women can breastfeed, and because of the lactation, the additional calories has to be about 600 kilocalories above, and that also includes increased amount of proteins and calcium and folic acid. Pregnant women with tuberculosis needs to be compliant with the anti-tuberculosis management, and a follow-up in the specialist centers need to be made, and these patients also need to be followed up by the A&M to check the compliance post-delivery.
Thank you so much, Dr. Poonam, for taking out time for such a detailed discussion on this important topic.
Thank you, Dr. Karishma.
So we have learned today that tuberculosis in pregnancy remains a major health challenge in our country, adversely affecting the maternal and fetal health. It can be easily diagnosed by the primary healthcare worker based on symptoms. Diagnosis can be confirmed by easily available tests, and treatment can be started at the nearest DOT center. These patients need to be monitored carefully during the antenatal period for maternal, fetal parameters and also for treatment compliance. These women need to be counseled adequately for rest, diet and supplementation. Delivered at any healthcare facility where neonatal care facilities are available. If diagnosed and treated appropriately, maternal morbidity and cases of congenital tuberculosis can be brought down tremendously. To know more about the management of tuberculosis in pregnancy, please refer to our protocols. Thank you.
That brings us to the end of this training session about the identification, management and treatment of tuberculosis in pregnancy. Remember to refer to the high-risk pregnancy management protocol for more details.